We'll just wait a second until we have the full group get going. Just another 30 seconds. All righty, this is a 20-year-old with a history of congenital heart surgery who is incomplete heart block and is programmed VVIR at 50 beats per minute. Question at hand is why is the rate closer to 82? So why don't we ask Dr. Capon what she thinks?
All right, so looking at this patient, 20-year-old, I agree with you. The rate is faster than 50. In terms of what we're seeing here, I think this might be a component of his rate responsiveness or her rate responsiveness, which is a part of a pacemaker setting. And the rate responsiveness aspect means that the actual rate of the patient's heart can vary based, or of the pacemaker, sorry, can vary based on the patient's activity level or physical demands. So it might be at a higher rate because she might be doing something that's more strenuous, or might be exercising or something along those lines, and that is what's allowing her to do so.
Okay. I mean, this ECG was presumably obtained in the hospital, so they weren't exercising. But yes, that's correct. So the R in the four-letter designation for pacemakers refers to the special functions, and in this case, it's a rate responsive function, meaning that it will detect motion and it will increase the patient's heart rate accordingly. And I think we've discussed this in the past. Pacemakers have different mechanisms for assessing motion or activity. Some of them can assess chest wall impedance. Some can measure respiratory rate. Some use temperature, but the most common is the use of a piezoelectric crystal, which can detect motion and will slowly increase or decrease the heart rate based on what it perceives to be the level of activity. This is actually fairly good response. It's, most studies looking at the rate responsive feature have shown that in general, they're not particularly sensitive. You can make them more sensitive. And as I've explained in the past, sometimes when you try to make it more sensitive, patients actually don't like that sensation. It can be very uncomfortable to feel their heart rate going up and down, just like you and I feel every day. But if you're not used to it, it is a strange sensation. And I've even had to turn it off in some patients who had never had it on before. So strangely enough, you would think that patients would feel better having better chronotropic competence, but in fact, and that is generally true, but I think probably the real answer is that the earlier you start in life, the better with it. So anyway, yeah, that's what this is. This is a patient who has rate responsiveness turned on. Okay, so simple question, good answer. Thank you very much. Let's move on here. Okay. So this is hold on one second. This is a teenager on postoperative day 2 following open heart surgery. And what we're looking at here is the Atri-Amp recording on this lead. What is a differential diagnosis of what is going on? And how would you consider treating this? So why don't we ask Dr. Marshall what she thinks about this?
Good morning. All right. So Looking at like across the screen, you can see that kind of almost in the middle of the screen, there's four beats that are faster than the remainder. And then when you're looking at the Atri-Amp in the middle, you're seeing that like spike before the QRS, which is showing that you're having that P wave before. Um, with it being, with those beats definitely being four like faster beats, it makes me
I
suspicious.
might also just mention, Molly, the entire left side of the screen, right, is basically faster than the right side of the
Yeah,
screen.
sorry, but you see it really.
Yes, you're right. The four in the
Yeah.
middle are certainly
Uh-huh.
faster, 100% correct.
And
Yeah.
then and then you see like what looks like a pause kind of dead center in the screen.
Uh-huh. Yep.
And as you move forward on the right half, you see definitely even what looks like a notch in that T wave, which looks like the P wave coming out at the on the second half of the screen. So on the left, that
When you refer to a notch, are you talking about something around here?
no, if you go up like in the second line and then yeah, and then keep going rightward
Uh-huh.
on the screen, you see like yeah,
I
that-
see.
yeah.
Well,
I'm not seeing that.
remember, of course, you do have an Atri-Amp, which will help you
Yes, you do.
identify where your P waves are.
Yeah. Which it does correlate with that on the right half.
Uh-huh.
Um, so then looking at the left, you're seeing those four like kind of faster ones, but even then before it, it looks like it's almost kind of speeding up into that. So to me, and I don't know if the rate was sustained at this 180 or not, because in theory, the teenager could have a heart rate of 180, but if you're seeing it, kind of sustained and hovering at that 180 would make me more suspicious for some type of narrow complex tachycardia. And then you're seeing it almost looks like you're seeing it kind of speed up even more towards the end and then terminate.
Hmm.
Um, with it, with the termination portion being sudden, kind of sudden off, that would speak to a re-entrant type of tachycardia. But then you do have components that are a little suspicious for some type of automatic, as you're seeing that R to R like shorten. And so a little bit of R to R variability, which would be more supportive of like an ectopic atrial tachycardia.
Right, right. So all excellent points, Molly. Really good analysis there. So um, the features that would go along with a reentrant arrhythmia, certainly the most obvious one would be the suddenness with which it terminated, right? It sort of seems to just suddenly go from a fast rhythm here to a more straight, normal sinus rhythm. I think this is more in like the 120s, and this is like 180, 190, something like that.
Mhm.
Um, and then, just as you said, the thing that would go against that being reentrant is the fact that there's a fair bit of R to R variability, particularly at the end here. It's unusual to see a reentrant arrhythmia change this much. Now, interestingly, in the EP world, we know that although we always say that reentrant arrhythmias are largely fixed and automatic can vary, AV nodal reentry will often have what we would term cycle length oscillation, meaning that the R to R interval will actually change a little bit, usually, but we're talking about 5 to 10 milliseconds from beat to beat, not this, which is really, even though we don't have the the boxes on the tracing here, I think we can all see that this is quite a bit faster than here. I mean, this is probably at least 10 to 20 beats per minute faster, not 3 or 4 beats per minute faster. I mean, it's just very obvious to the eye. So, and the other thing we can say is, we see this P wave or atrial depolarization. And again, it's either before every QRS or it's after. If it's a reentrant arrhythmia, presumably it's going down the AV node, up a pathway, atrium depolarized down the AV node, up a pathway, atrium depolarized, or alternatively, it's a primary atrial tachycardia that just sort of heats up and then terminates. And, it's important to remember that although, we teach rules like automatic arrhythmias warm up and cool down, and reentrant arrhythmias are more slowing, or reentrant are more automatic on, and I'm sorry, suddenly onset and offset. Um, these rules are only general rules. That's not true for all arrhythmias. And part of it may be that, for example, EAT may actually be a reentrant atrial arrhythmia from a single focus. It's hard, we don't really know mechanistically how it is, and probably all EATs are not exactly the same. But I think probably this is some kind of ectopic atrial tachycardia. Now, if you are taking care of this patient and you wanted to know, well, what could you do? May I ask Maya? Well, so we have this possibility that this is an atrial tachycardia, but Molly has appropriately suggested that it is not inconceivable that this could be a reentrant arrhythmia. Is there any way that you could figure this out, Maya, at the bedside?
Yeah, so there's a couple things. So if you're in the tachycardia, one thing you could do is give adenosine and run a rhythm strip at that time and see
Uh,
what.
okay, and what would you do exactly? So you have the patient, you give adenosine, and what are you looking for?
So you're looking for, so essentially if it was like an ectopic atrial tachycardia, you would continue to see P waves, but you wouldn't see the QRSs after
I see.
them.
I see. So you're saying if you happen to be in tachycardia, you could give adenosine, and if it terminated, it would suggest an AV reciprocating tachycardia. And if the atrial depolarizations persisted, then it would be a primary atrial arrhythmia. Am I understanding your view on that correct?
Yes.
Okay. What if the patient was not in tachycardia? So we see this on the left-hand side of the screen. It goes into the thing on the right-hand side, and we don't really see this very often, or maybe there's a few beats here and there, but really no more sustained tachycardia. What would you, is there any way if the patient were not in tachycardia that you might be able to rule in or out either of these diagnoses? I mean, presumably if you could rule in one of them, it would probably rule out the other, unless you were very unlucky and you happen to have both.
And you're saying at the bedside when the
Yeah.
patient
So the
is
patient's
not
in the
in
ICU,
tachycardia.
they're not in tachycardia. Let's say now it's post-op day 6. The patient is doing well. You know, there have been, a handful of 2 or 3 beats, but almost exclusively in sinus rhythm. But the patient's cardiologist wants to know, did they have, what did they have? Because they want to, maybe prepare for the future, I would say. So let's say that Dr. Pastuch goes on rounds with you and says, can I take the wires out? Is there anything we could do with the wires before they come out that might help us?
Um,
So if this were, so the R to P interval is pretty long here, right? It's definitely more than 70 milliseconds. So if this is reentrant, it's almost certainly not AVNRT. It could be, right? But again, it would have to be an atypical form of AVNRT. But is there anything you could do with the wires to help you?
um, I guess you could try to like if you are
Mhm.
trying to see if there is like an accessory pathway
Yeah.
or something, you could try to pace the ventricles and see if you're getting um like
Right.
atrial depolarizations.
Okay, so if I pace the V and I see ventriculoatrial conduction, which would be demonstrated by an A after every paced V, um, that's probably not enough, right, to prove that there's a pathway, because patients can have VA conduction through their AV node or through an accessory pathway, right?
Yeah.
So how would you distinguish between them? You're getting very, very, very close to the right answer. That I would pace the V, but how could you prove that your VA conduction is now, if there's no VA conduction, then that would certainly suggest the likelihood that this is not a reentrant arrhythmia or an AV reciprocating arrhythmia. So I agree with that completely. If there's VA block, if you're just pacing the V and there's no VA conduction, then yeah, it seems most likely then that what we're dealing with is a primary atrial arrhythmia. But if there were VA conduction,
You could pace at like faster rates and see if you're getting decremental conduction.
okay, right. So you could do ventricular extrastimulus testing right at the bedside and actually do like a little mini EP study right at the bedside. Bring up this stimulator. You know, we have this brown box, which we very rarely use, and we can do extrastimulus testing at the bedside, and we could see if the VA conduction is decremental. If it's decremental, what does that suggest? Is there a pathway or not a pathway usually? If
If it's decremental, that would suggest it's the AV node rather than a
right, that would
pathway.
suggest that VA conduction is via the AV node. And again, what we would be looking for is to see what happens to the VA interval as we get more and more premature. Is there anything that's even simpler, like if we paced the V and we gave a certain medication, could that help us? What would happen if we
Like
paced the V and gave a dose of adenosine?
so if it was like a pathway, then you would then it would not block, but
Right. That's
it
exactly
would
right.
block if it was the AV node.
Right. So that's exactly right. See, you should go into EP, not this bullshit imaging. So yeah, if you pace the V and you have persistence of VA conduction in the setting of adenosine, we know that in general, and again, these are only general rules, but they're largely true for most patients, there should be persistence of VA conduction in the setting of adenosine if there were an accessory pathway, or you should see VA block, which would be suggestive of the path of the conduction going up the AV node. And so that would be a good way to sort of rule in or rule out the presence of an accessory pathway. In this case, I believe the patient really didn't have this ever again. And so it was assumed that the patient had an atrial tachycardia. Now, let me ask you this. Can you tell from the morphology of the atrial depolarization what this is? In other words, this is the Atri-Amp and this is the atrial, you know, it's very nicely augmenting the atrial depolarization on the monitor. By the way, Dr. Smerling was very impressed that we have this at all the bedsides. He says it's very expensive, and at his last job, they would not pay for this. Is there anything about this signal that tells us anything? Does the morphology help us?
I mean, it's a different morphology than what I presume is the sinus rate, which is the ending
Yeah,
few
I think,
beats.
right. So it
Uh,
isn't sinus. I think we can say that, right? I think you're
mhm.
right. You know, this is the atrial morphology on the Atri-Amp compared to this, and I think we would agree that in the tachycardia, the impulses look pretty much the same, and in the sinus, they look different. So we can say that this is a different rhythm than this. I think that's a reasonable assumption, even though it's only a single lead. But we can't really say whether this is a retrograde P wave or an antegrade P wave. All we know is it's not the same P wave as this P wave. So, so it's an interesting tracing that was provided to me. So thank you. I think the fellow knows who gave me this tracing, so thank you. Okay.
One question about this.
Yes.
It does look, I mean, if I had the calipers, I would maybe march it out a little bit, but it does look like those 4 beats where it gets faster in the middle, the PR interval is perhaps a little bit longer. Was
Hmm.
that something that
Okay. I can't tell.
discussed?
It's a good question. It
Or
might be. You're right. We would probably have to take a caliper. So if the PR interval were getting longer, so if this were some kind of pathway mediated tachycardia, then the implication would be that the AV conduction is getting longer. But I don't know that it would help us because if you're going down, I mean, the assumption here is that because the QRS is the same in every lead, both in the left and right side of the panel of this tracing, this is some kind of supraventricular event, whether it's EAT or ORT. And so in either event, you would be going from A to V through the AV node. And so as we get faster, right, we would expect that the AV node is going to decrement. So it is not surprising that the PR interval would be lengthening if the tachycardia rate is increasing.
Mm-hmm.
Yeah. Okay. All right.
Okay. Thank you.
Thank you. All right. This is a 13-year-old in the emergency department. And the question is, what is the differential diagnosis and how would you treat this both acutely and chronically? So let's talk to Dr. Mukhopadhyay.
Good morning, Dr. Paz.
Resident expert in mapping of the conduction system.
Can you hear me? Okay. Looking at the rhythm strip at the bottom, the rate appears to be around like 180, 190.
Okay.
And
is it wide or narrow?
this is seems to be it seems to be a narrow complex tachycardia.
Okay. So if you just stop there, you don't even look at the tracing, and I say to you, 13-year-old with a heart rate of in tachycardia at 185, what are you thinking in your head?
I would be if I'm not able to see a P wave, if I'm thinking it's a non-sinus tachycardia, then I would be thinking of AV and RT.
Okay, and why is that? I don't disagree, but why do you say that?
I think it's because of the rate. It's an adolescent, given the age group and the rate of the tachycardia.
And what about the rate makes you say that? And by the way, I agree with you, but just for those who may not be as familiar.
For AV and RT, the rates are usually in the 180s, 190s, as compared to if there is reentrant via the ORT, where it's like more, it's higher than that.
Usually that's true. So I agree with you again, you can't hang your hat on that, but yes, in general, for a teenager, we would expect that AVNRT might be a little bit slower than ORT. So yes, I agree exactly with those heart rate suggestions. Okay, anything in this tracing that helps you make that diagnosis? So even without looking at the tracing, if I just told you narrow QRS tachycardia 180, 190, you're thinking in your head, this sounds to me like it might be AVNRT, but it could be ORT. Now, looking at the tracing now, any clues that help you or?
I'm trying to see if I can see a P wave. One, two, like if I'm looking at V1, then I'm one, two, three. There seems to be a small notch before the fourth QRS complex. The fifth one.
Here?
No, I'm talking at the rhythm strip at the bottom.
Okay.
Like there's a small notch in front of the fourth. Like yeah, like if
Right
a
here?
small. No, and before the QRS complex, like that
Over
small.
here.
Yeah, that thing.
I mean, if this is reaction tachycardia, how commonly does the atrial depolarization precede the ventricular? It's pretty unusual, right?
Yes, yeah.
Could that happen in AVNRT?
Um, Trying to think if there's atypical EVNRT, we
So if
might.
atypical, the RP interval would be long, right?
Yeah.
You know, in AVNRT, remember that the reentry is occurring in the AV node above the bundle of His. And so that the atrium and the ventricle are really sort of like depolarizing passively with the AV node reentering between them. And some patients, you can actually have, we always say that the RP interval in AVNRT, typical AVNRT, is less than 70 milliseconds. It actually can be negative. You can have an A that precedes the V. If it takes less time to go from the AV node to the atrium than it takes to go from the AV node through the His bundle into the ventricle, the atrium may actually depolarize marginally earlier than the ventricular depolarization, but in my experience, it's very difficult to see that on the surface ECG. You can usually only see that or make that diagnosis when you have intracardiac electrograms and you can actually measure them. But so you might be right, Katoki, that you are suggesting that maybe this little tiny notch here is actually an atrial depolarization preceding the QRS. The purpose of this tracing was just to really go through what you just did already, which is just looking at the rate and the narrow and sort of getting the correct differential diagnosis. But I think the other point is simply that it's not obvious that there's a very clear retrograde P wave. Maybe in this lead, you could make an argument that this little notch here might be a retrograde P wave. It's hard to say. If you had the 12 lead out of tachycardia, you might be able to compare the complexes in sinus rhythm and in tachycardia and make a determination of which of those diagnoses this is. So, okay, so you're in the ER, you are the cardiology attending, and you have a new ER attending. They're very frightened of this rhythm. So what are you going to advise them to do?
So we already have an EKG.
Yep.
I will ask, and it's a 13-year-old, so I'll ask them to do some vagal maneuvers to see if this terminates a tachycardia.
Okay, and how would you do that? What vagal maneuvers would you recommend?
I mean, this is a 13-year-old. I would ask them to sip on a straw, like do Valsalva, or sip on a straw, or do a knee chest position, or yeah.
I mean,
And
the most typical is to ask the patient to strain down as if they're having a bowel movement. That's probably the easiest and most common vagal maneuver in an older child to do. And that's what most patients do. Okay, so you do that a few times. If it doesn't work on the first time, is it worth keep trying?
no, then I'll do something else. I'll ask.
Actually, that's you actually would normally recommend to try a few times. So when I have patients at home, families often ask me, what should I do if I have tachycardia? And I'll often say, try vagal maneuver 10 or 15 times. It may not always work on the first, fifth, or even 11th try. So it's always worth trying a couple of times. Doesn't always work on the first try. There are some patients, you would think it would work equally well or poorly, no matter how many times you try, but actually, clinically, I can tell you that there are many examples where patients may take them 10 tries before they can break it. But okay, so you've tried 10 or 15 times, it's not worked. So what are you going to do now, Kentucky?
I'm going to try adenosine at
Okay, how much?
0.1 mg per kg per dose.
Okay, so you give that, it doesn't work. What would you then do?
I'll try again.
Try again at 0.1 mg per kg?
At double the dose.
Right, at 0.2 per kilo. Right, exactly. And if that failed, what would you do?
If that failed, and I still think this is a reentrant tachy, I would like to try to do some synchronized DC cardioversion with about
Okay, if the
0.5.
patient looks well, though, I mean, do you want to sedate the patient? So let's just say the patient comes in, they just came out of Dunkin' Donuts before they came here. The mother stopped off there on the way, and he had 2 donuts. So now he's in your ER and he's in this tachycardia. So you really can't easily sedate him unless he were dying in front of you, but he's not. So anything else you could do, Shai? I agree. DC cardioversion, synchronized cardioversion at 0.5 to 1 joule per kilo is reasonable. But what would you do if the patient looked okay and had just eaten? Right, we'll sedate and intubate people who have on a full stomach sometimes if we have to, if it's an emergency. But this probably is not an emergency because the child looks well. So anything else you could do? You've already given solid dose of adenosine, which unfortunately didn't work.
I've never used it or seen it done in front of me, but I think we can use verapamil It's
Right,
an
you could-
adolescent, so we can use verapamil for
Yeah,
him.
you could use verapamil, you could use procainamide, you could use amiodarone. You can really use many different agents. You could give the patient a dose of flecainide. I think Barry does that sometimes, right? He'll give a patient a big dose of flecainide. You know, if this is an adult-sized patient, you could give them like 100 or 150 of flecainide one-time dose, and see what happens. Normally, I would use an IV agent myself. You're already in an emergency room, you have intravenous access. I would probably use procainamide myself. Give a load of maybe 5 per kilo over an hour or two and see if that breaks. And even if it doesn't break, sometimes once you have given a load of an agent, if you then give adenosine, it will often work when it didn't before. So always keep in mind that once you're in the hospital and in a monitored setting, like in an emergency room or an ICU, you have the opportunity to give IV agents. Cardioverting, if the patient looks unstable, you're absolutely appropriate to DC cardiovert the patient immediately, sedate them, of course, but then cardiovert them. But if the patient is not looking clinically decompensated, then you have the option to try some medical management. Any questions about this? All right. Okay, thanks everybody. Hope you have a great day. See you at Sinai a little bit.
Thank you.
Thank you very much.